Okay, so this is our hot topic today. I want to introduce you to my patient. She's allowed me to.
Get Mindy.
Sorry, I thought you were going to present more of you.
No.
Okay, sorry. I will do much. Swiss, we have to be on time. So I want to introduce you to Mrs. Faina. She came to my clinic as a referral from a doctor that likes me. Not that he doesn't like it, but he sent them to me because he tried to deal with the situation himself for the past 30 years, and he couldn't manage. So he sent her to me. Look, she's 76 years old. She has osteoporosis and high cholesterol. She had an implant while she takes some medication. 3 implants in the area of the lower right jaw, and one of the implants failed, and it was taken out by the other physician, and it is closed after one of the complications. He didn't know, and he couldn't. I think he missed out the fact that she's taking IV Prolia. Somehow, because he has an implant, somebody that put the implant itself in. And I think the one that first to do the implant didn't see the charts, what she's taking. He just came to put 3 implants in 15 minutes, and this is what happened in finished, and he didn't read the files. And the implant, one of the implants fails, he took it out. He didn't close down. He said, oh, it's a terrible problem. I will put a tissue. He put a tissue, so we can manage surgery that takes place in this one, and still didn't close. And then for half a year, the patient complains, I had pains, it is open, I have sensitivity, I have a bad smell, because the chronic bone can be smelled, something dead in the body. And then he referred to me, you know what, go to Maisie and see what you can do. So she presented this panoramic. You could see something here. Lost, so you could see the 2 implants, and of course the third one was failed, it was not there anymore. And when I did a CBCT, I saw like a detached bone. You could see that the structure of the bone is different. You absolutely can see it on the X-ray if you analyze it correctly. And I understood immediately she has a problem. And in 2 days, she got a treatment from me, because those patients for me are emergency. So I took out the regular patient, which is maintenance, or do something that I can do later on, and put her inside for a treatment. Now look what she came with. You could see the tissue. The tissue never lied. The color of the tissue gives us the story. This is an inflamed tissue. This is a tissue that doesn't want to adhere to the bone. We know nice tissue is a tissue that it's a colorless pink, and it sits on the bone nicely, and sometimes you have stippling very nice. So you could see a healthy tissue. This one is not healthy. And what I need to do is take out the bridge and see what exactly there is under it. And I can see here the bone. This is a dead bone. It looks like the color of green, a bit greenish and yellowish. So, and I also touched it inside, and I felt this is moving. I understood immediately this is necrotic bone. I told her the situation. I explained it to her, and I was giving her the understanding that I can treat it, because she started rid of it. And it's panicking because, one of the situations if you wait is to cut the mandible. There's some of complications that happen. And I told her, let's try first, keep it simple, and I will show you what I did, what is the protocol. So before I show you the whole scenario, what I did, I want you to understand about the osteoporotic. Every 3 women has it. Okay, this is quite tremendous. So please, when a patient comes to your clinic, ask him what he has. Read his chart, read his medical history, read it, understand it. Don't just treat him. Also, dental hygienist. You have a patient, read the file, the medical file of your patients. Because you can miss the understanding that maybe he has something that we need to be sensitive about. So, and for men, that's not a surprise to me, because I have men coming to my clinic with osteoporosis, and they take medications as well. So now also men has it. Part of the symbols that we can see on patients, the back, you can see the women have also the men, the back is falling, rolling down. So you know that those people have osteoporosis. And one of the things about osteoporosis that they need to do is not just, let's say, take a medication, but they need to start treating themselves with a special diet, taking more things that including calcium and vitamin D, and sleep correctly, go sports activity. Sports helps everywhere, but also for osteoporotic patient. And nowadays, where the young generation knows that the longer they do sport, then they can postpone the option to get osteoporosis because the depth of the bone is stronger. So the longer you do sport, the chances to get osteoporosis is decreased. Okay, so what is actually the definition of medical-related osteonecrosis of the jaw? This is when we have a necrosis due of taking medication for osteoporosis. Those medications, what they're doing, I want to keep it simple for all of us and for our patient. It makes our bone like a glass. That means there is no resorption and no building. Okay, so there is no. We always say if you walk, we have something that builds and something resolves. Something that builds, something resolves, like in orthodontics. Okay, but when we take this medication, this process is stopped. That means there is no breakdown, but there is also not a build-up. So it's like a glass. That means the patient also they can also fracture easily. So I always take care of those patients, help them to sit, help them to stand up, make sure nothing is I really understand the situation of those patients, and I take care of them. So this is what is medication-related osteonecrosis of the jaw is due to medication. Now, which kind of medication can cause it? Like you can take this list and you can understand that the cluster and the meta and aldronate and risodronate and all of those medications supposed to help osteoporosis. It does help osteoporotic patient, causing other issues in the body. And the patient needs to understand this. This is why sometimes you meet patients before they take the medication. They come to you to your office to be treated dentally. So, okay, do whatever you need to do because I need to take this strong medication I cannot do any dental treatment. So finish my treatment before I'm taking. And this is a good understanding to the physician today that gives those medications and send those patients to us. There are other medications as well that's used to treat like cancers or osteoporosis and cancer-related bone that also can cause to those kind of osteoporosis of the jaw. If we don't know the medication, but the patient tells us that he's osteoporosis or he's having cancer that led to the bone, we always need to check the medication. There are things we don't know, and it's fine. We don't know everything. A lot of the time, I don't know the medication because it's another name. So I'm going to Google and searching. I'm asking AI sometimes, but not all the time it's a true answer. So we need to verify what the AI is saying. What are the risk factors that we have? Patient comes to your clinic saying, I'm taking medication. Fine. Say the name of the medication. Okay. Next questions. How do you take it? Is it tablets or IV? And how long? How long do you take it? If it's 5 years, for sure it's already in the bone, this medication. It takes time until those medications are taken out of the body, sometimes about 10 years. So we need to understand the duration. The longer the patient takes, the more risk he has to have a dental treatment, and we need to bear it in mind. So this is the duration, and what we need, this is prevention strategy. So before they're taking the medication, we need to do pre-treatment, dental treatment, do whatever we can. If it's an SOS medication, sometimes patients say, I need to take it tomorrow because I have cancer and I need to start this medication. So we have to be more radical in our treatment before they take the medication. And sometimes they have time, if the doctor gives them about 1 year, half a year, say, yeah, you have half a year to finish your dental treatment, then you need to finish all the surgeries you can put inside this half a year. If it's implants, if it's extraction, all the rest. Regular dental checkups for those patients, and who is hygienic here. If somebody is also a chronic patient, he take medication, or even if he doesn't, he's also chronic, every 2 months, checkup and cleaning before oral hygiene instruction is very important. So we won't get complicated. Okay? We don't want those patients not to take care of the mouth, it's starting a complication. And what else? That's the next one. Education the patient about the importance of oral hygiene that we said. Okay, treatment strategies for those. So conservative management. If we have patients that already had taken osteoporotic medication, then sometimes we think about giving him antibiotics. Why? Let's say he has a deep pocket, okay? We don't want it to get inflamed. We don't want it to get bacteria inside, and we don't want the gums to be open. Sometimes we need to give an antibiotic, and we need to give the antibiotics for sometimes longer duration. Let's say a patient comes 5 years of osteoporotic medication. I give him for 2 weeks antibiotics. It's something that is established. You need to, if you do something radical, you need to be more radical with your antibiotics. And I normally don't like to give antibiotics. But those patients are in a risk of developing osteonecrosis of the jaw, and we don't want it. And it is protecting them. And drug holiday. So if somebody needs to go through a very, let's say, extensive treatment, give them a drug holiday between 4 to 12 months. This is what established in the literature. That means if it's taking a long time than osteoporotic medication, you give maybe 1 year drug holiday before you want to do something extensive like extraction or something like that. But if you just start to take and you want to do something, then 4 months would be also possibility to have a drug holiday. Surgical option, because today I will show you the case. It's a debridement and resections in severe case. This is the resection of the jaw. We hope you not get there. But debridement is also taking out the bone that is the necrotic bone from inside the body. Then the body can heal because something dead without a blood supply wants to get out. Okay, so we need to help it to get out. And coordination among healthcare providers. That means that I almost always talk to the physician that gives the medication, because sometimes the patient doesn't know, especially older patients, they don't exactly know what they're giving. So I'm calling the doctors. I'm in touch with, okay, what he's taking, for how long did you change the medication? What do you think about his other health status? What he has more? What kind of other medication is supposed to take? You want to transfer it. Sometimes there is medication which are not causing to osteoporotic and they're still for doesn't cause to osteoporosis of the jaw, and it's still for osteoporotic patients. So investigate. That will help us to understand how to treat. And this is the stages of the medical-related osteoporosis of the jaw. Stage number 0. What is the treatment strategy? If you want to take a picture of that, it's also for your hygienist, because it's patient education, reduction of something that the risk factor. That means patient is smoking, taking alcohol, and doesn't do sport. We are physicians, we are doctors. We want to help our patient. We need to bring the awareness up. It doesn't say his physician doctor every day. He sees us every 2 months. We can be feeling that the setting. How is your sport? What did you eat for today? I care about it. I'm sure you do as well. This is why you're here. So educate as well. You know, if you do sport, if you walk more, if you eat properly, it can help your status. You know that? Or if you clean better, it can help your status of your disease. And pain control and antibiotics if needed. Okay. So stage number 1 is again patient education, reduction of risk factor, pain control, and also antibacterial mouth swings. Consider surgical debridement. So this is patient that comes with a problem and they have some necrotic area and you need to treat it. But it's not so not so big. We give antibiotic, we take out the this necrotic bone, and this is stage number 1. Stage number 2, we have the same, but we need to give a surgical debridement and relieve soft tissue irritation and infection control. That means to educate him, to give antibiotics, to take out the necrotic bone, and to have nothing to touch the area of the tissue. Any irritation while closing the tissue can open it. So you need to give special instruction to your patient. Do not touch this area. Don't touch it with your tongue. Don't eat on this side. So we can heal the best way you can. And then we have the stage number 3, and this is resection, which is already, this is an extensive treatment, and it's a bit more extensive, and this is more for the hospital time. This is the stage number 2, by the way, which we can treat. So let me show you the case. As you saw, I took out the necrotic bone, and I also took out the implant over here because it was failed. Nothing was attached to it because necrotic bone attached to it is actually interfering to the healing process. So I took out this implant as well. Suture, I put over there, I will show you what stated, but I put over there crossing hyaluronic acid and I wash it. Before I put the crossing hyaluronic acid, I wash it with 3 to 6 saline. So I took out the bone, I did a little bit of debridement to see that there is bleeding. One of the most important factors, if you see bleeding, you can be relaxed. Because if the bone is bleeding, that means the healing will come, also the tissue around it. I took coagulation inflamed tissue, which I saw, I cut it out, and I put some of the crossing hyaluronic acid and suture it, and look at months of healing. Of course, antibiotics, and you could see the months of healing, and you can see 6 months after healing. I already put a crown here on the implant, and and after it's all, everything was, you can see the tissue, it's all healed. She got, I wouldn't put the implant there again. She got a removable denture. 5 minutes, okay. So this is, see before, look how extensive it is. You can see the canal in this area, and look at that. This is nature. I didn't put any bone, it just grew. Because it has the opportunity, even though she's also a chronic patient, the bone grows. This is what I did. If somebody want to take pictures, oral hygiene instruction, drug holiday, I called her doctor, sterile condition, remove any tension and irritation. I took out the bridge that she had. I gave antibiotics. I covered with a cocktail, Dalacin and Flagyl, because she was allergic to penicillin. And it was for 2 weeks. And I was rinsing with Bluem mouth. This is the wound dressing, if somebody knows the Bluem. Wash the saline inside this area for 260. Take out the necrotic part, and of course make some debridement. Wash again with 260 saline, crossing hyaluronic acid inside the wound, and suture it with nylon suture, 6-0, and postoperative mouth rinse with Bluem. Okay, this is what I did, and it healed. Because when we know biology, we know how it will, what will at the end of the day will happen. We go for our 5 minutes of diabetes, more aware of diabetes. This is a patient, 6 years old, he has a diabetic type 2, A1C was 7. He also had a renal cancer for 5 years. He's taking glucophage. He has a pain and bad breath and bleeding and hyperplasia of his gums. The doctor saw that he has some allergic response to his old crown, so he put a temporary crown. It didn't help, and then he referred him to me. You could see the inflammation, and of course, diabetic patients are more susceptible to respond in a extensive and more. They have the response they're more sensitive. So you could see the response that he got in his gums. It was painful and sensitive. And I want to show you that in hygienic phase, only hygienic, of course, for the instruction, hygienic phase, they're the same, even they're the same, the diabetic and periodontology. Periodontal problem is related, and also to talk to his physician to maybe see what we can do with the medication. But at the end of the day, wait a minute, you could see This is only hygienic phase. It's saline and root planning or hygienic structure and crossing hyaluronic acid on inside the pocket. And I can show you what I did. And if you know the literature about cross-linked hyaluronic acid or hyaluronic acid, in diabetic patients, it was treated for other parts of the body in order to accelerate the healing. And we know it's accelerated healing, of course, in the mouse with the fibroblast and gingivoblast. And another thing I want to show you, also just a check, 75 years old, A1C level 9.4. What, not to treat them? No, to treat them. Hygienic phase, we can treat everyone. Oral hygienic structure and hygienic phase, we treat everyone. What's the cost? This is very important to reduce an inflammatory state. And look what's happened. From that, you got a bone. I didn't put anything. It's just hygienic phase. Because we took out the problem, we took out the granulation tissue while I did the scanning and root planning, and we got the bone instead of it. And the A1C level was reduced at the end to 7.1. This is a follow-up of 1 year. And the bleeding problem was reduced because he was coming every 2 months to my clinic. Why we need the cross-linked hyaluronic acid? Why we need it? So I want to tell you about the wound healing, and this maybe will be my last slide. Wound healing in periodontology is like that. First of all, if we do hygienic phase, or if we open and close the flap, we will get a long junctional epithelium and reattachment. That's what's happening usually. What we have, we get that. We don't have new cells. Sometimes we get ankylosis and root resorption. That means that it's not a good wound healing. We don't want this wound healing until it's when we have a trauma, it's when we have an orthodontic treatment. It's something we don't like, but it can happen, and we need to know how to diagnose it. But we like to have new attachment. That means new PDL cells, a new cementum, or regeneration, which include also new bone. That's what happened to this last patient, by the way. We need to have the biomaterials to help to accelerate the healing. The faster the healing, the faster we will get regeneration. Because there is no other cells to come and penetrate, so instead of the good, healthy cells to come. Diabetic Day, it's on the 14th of November. We know what is the symptoms. We know what is the problem. We have 3 types. We need to know them, type 1, type 2, and the sessional, the one that is pregnant. We mostly dealing with type 2 diabetes, and I want to focus on that. This is the more, let's say, heavy patient, insulin resistant. The cells are failed to respond. He has insulin, but the cells in his body doesn't respond well to the insulin, so they cannot bring the channels to take for the glucose from the bloodstream into our body to inside the cells. What helps, to bring out those channels? Fort. Fort helps to bring the GLUT4 up into the membrane and helps to take the insulin and helps to take the glucose inside. Diabetes, we have every 11 out of 1 of every 4 is probably have diabetes, and 1 of every 11 patient come to us. Hemoglobin A1C level is important. Please make sure it's done in the last 3 months and not 1 year ago, so you can actually know the correct A1C level. And for me, ABC, this is the therapy, the treatment, but also dental and periodontal treatment. Don't forget, it's part of the treatment because periodontal problem is a 6th complication of diabetic patients. 6th complication, but also we have gum disease. I have lots of research about it. I'm sorry I don't have the time to show you. Somebody wants to stay for the next session, I might show it and I might be able to be doing it fast in the right time. What is important for you to know, every hygienic phase, we can help to reduce 0.5 A1C level. If you take a measurement, and I did take a measurement before, and 3 months after, you have another blood test, you can see the A1C level is reduced. Of course, the patient is to clean, and your hygienic phase needs to be superb. We know the connection and the links. This is bidirectional. If you have worse condition in diabetic, then the periodontal problem is increased, and vice versa. If the periodontal problem is huge, it will affect the diabetic situation. That why the patient comes to your clinic. You do, first of all, systemic phase. You understand the situation, what he's taking, what kind of medication he's smoking, and what kind of medication he takes. Then you stop a bit, you think him. You also talk with him about the food, the diet, and of course, you taking the measurements of the hemoglobin A1C level, and then you understand where your patient is, and always do the hygienic phase, and then you do again checking the A1C level, and you can go to the correct phase if there is after 7, the 8, and lower. Yeah, hemoglobin A1C level is lower. Okay, you want me to? I really want to show you that everything we do in diabetic and diabetic patient will need all of that. They will need extraction, regeneration, periodontal surgery, implantology. The success depends on the wound healing, and the wound healing affected by the glycemic state. So if you want good results, make sure the A1C level is reduced less than 7. You will get better results, like a healthy patient. And if it's 6, it's a healthy patient. That's what we like to have. Always bear in mind that if we had high glycemia, the advanced glycation end product is increased. That will give us poor healing, because the hyperglycemia causing to those cells and products to give us altered fibroblast and osteoblast tissue, and this is a poor healing. Bone poor healing and also tissue poor healing. So make sure you have to always bear in mind to the patient. You want good results, you have to work with yourself. It's not just me. Okay, can have a magic hand, but it cannot influence your A1C level. You need to also work for yourself. Some research that we did on diabetic animals, and what we have wanted to know how we can improve the wound healing and how we can improve the bone. And we could see that if we give anti-inflammatory agent like cross-linked hyaluronic acid, we will probably reduce the option of the membrane to degrade faster. That means the membrane can stay longer when you do a GPR or GPR procedure. And this is what we did. We took a cross-linked hyaluronic acid together with membrane. We implanted it in a diabetic friend. We saw that the cross-linked hyaluronic acid released in a slow release mode for 10 days. That means the whole healing process is accelerated by the hyaluronic acid. Okay, I need to finish, I think, because he's sending, and I need to finish. I just want to have your conclusions to say take home message. Sorry. Take home message. Use the protocol. Systemic phase, hygienic phase are very, very important to help our patient, and to use cross-linked hyaluronic acid in my, and I don't want to sell you anything, I'm not here to sell, I'm just saying my experience, is when I add it to a systemic patient, like diabetic, like osteoporotic, like also other patients, it helps to accelerate the healing for sure in the hygienic phase. So I want to thank you by that. And if somebody wants to know my details and wants to write to me, I'm also having a YouTube channel called Perio Home when I show all my surgeries. And this is my email, and I have a website, and this is my phone number. I'm answering on WhatsApp, regular phone. If somebody wants to consult, something happened, some necrotic, you don't know how to treat this, consult, I'm trying to answer. Thank you very much.